Welcome to this morning's session, or just before lunch, the Developing a Digital Health Roadmap, the Cleveland Clinic Experience. My name is Nikisha Beckford. I am VP of Marketing Strategy and Business Development at Daniel Bryan Advertising, and I'm very excited to introduce this session today. Just a reminder, we're going to ask you to please turn off your cell phones and that you hold all of your questions to the end, but if you do have some, the gentleman would love to take those throughout as well. Finally, please make sure you've heard, I'm sure, lots, to fill out the evaluation in the app or in the email that you get at the end of the day. Now I'd like to introduce our two speakers. We have with us Dr. Peter Rasmussen, the Medical Director for the Cleveland Clinic and CEO of Damo Consulting, Paddy Padmanabhan. Welcome, gentlemen. I'll turn it over to you.
Thank you very much, and good morning and welcome, everyone. We're going to start with a quick set of polling questions with a show of hands. How many of you work in hospitals and health systems today? Great. How many of you have a digital transformation program underway? Great. How many of you have a chief digital officer? Okay. How many of you have a digital transformation budget? Okay, the numbers are getting smaller. Not surprising. I just want to say that this is indicative of the fact that healthcare is in early stages of digital transformation. And I'm going to share some research at the beginning of this presentation where we talk about the findings from a study we did where we talked to 40 healthcare CIOs. I'm going to come up to that and you'll see what really the current state of digital transformation is in healthcare today. So, the forces driving digital transformation, I wanted to spend a couple minutes on that just to set the context here, right? Most of this is not new news to anyone here. Everyone is looking at the shift from fee-for-service to value-based care models, and that comes with a lot of expectations around how you're going to manage the healthcare business. Healthcare consumer is upon us. Consumers want convenience and they want superior experiences. And how are we going to deliver it to them? Talent shortages are a reality at every level of the organization for every type of skill that you can think of. So automation is therefore a reality as well. A shift from hospital to home-based care, the virtualization of care is well underway. And last but not least, I think this is advancing without a prompt, so I'm going to try and see. Okay, I'm going to make it manual. It was somebody had set it on a timer, wasn't me. I'm going to go back to the previous one. Okay, non-traditional players. I was going to finish up with that. The emergence of non-traditional players is very, very visible, and non-traditional players within the healthcare ecosystem as well as from outside of the healthcare ecosystem. And some of these companies, some of these enterprises have very big plans for the market, and they have very deep pockets as well. So they're going to stay invested in order to achieve their goals. So all of this is driving the need for transforming the enterprise today. And digital transformation essentially means you're using technology to drive the transformation. Our research, my firm has been doing ongoing research on this, and our research shows that there are 4 different models that health systems fall in today. Model 1 is fairly straightforward. It's very EHR-centric, so the digital strategy is pretty much, hey, fill in the blank with your EHR vendor name. That's my digital strategy. And essentially, it focuses on optimizing the existing investments on the EHR platform to get the most that you can get out of the platform. And whatever be the functionality that's available, you turn that on, and whatever is on their roadmap, you're going to wait for that and turn that on. In the second model, you're going beyond the EHR systems and you're investing in the virtualization of care. So telehealth, which is very much a reality, remote monitoring, hospital at home, all of that falls in this category. So it's a large-scale enterprise shift towards the virtualization of care. In Model 3, you've got health systems that are investing in point solutions that are based on needs, and you might have needs coming up from different departments, different functions, and you evaluate each of them on a case-to-case basis and fund them and implement them. But they don't necessarily form part of an enterprise digital strategy. It's doing it to me again. And Model 4, which is where the Cleveland Clinic is, and Dr. Rasmussen is going to talk about that in detail. Enterprises are taking a step back and making a long-term strategic bet on digital transformation. They're looking at digital transformation across the enterprise. They're bringing in stakeholders from across functions and across departments. They're looking at what the enterprise goals are and aligning digital roadmaps and the digital transformation strategy to enterprise goals. Along the way, they're also making strategic bets on one or two technology partnerships in addition to the EHR partnership. And they're also looking at harnessing the digital health innovation ecosystem, which could be internal. It could also be from the startup ecosystem. We find that most organizations are somewhere between 1 and 3 today. A number of leading organizations are at 4. And as I mentioned, Cleveland Clinic is one of them, and Dr. Rasmussen is going to talk about that. I mentioned that I was going to share some research that my firm had done, and this is really very recent. We did this in June. We talked to about 40 different healthcare CIOs, and we asked them a bunch of questions and asked them for their views on what they're doing with regards to digital transformation. Firstly, digital transformation, we were told by most of our respondents, means reimagining business processes and customer experiences. That's what most of them told us. A good number also told us it's about delivering healthcare when, where, and how your consumers need it. So that's really what people are thinking about when they're talking about digital transformation. And it seemed to us that healthcare CIOs have a pretty good idea today of what digital transformation means for their enterprise. And it's also consistent with what other sectors, such as banking, insurance, e-commerce, manufacturing, have gone through or are going through, and they're a little bit further ahead of healthcare in that regard. We asked them, where does this chief digital officer role sit within your organization? And a little over a third told us it's part of the CIO role. And interestingly, almost a third told us they don't have a digital function. It's, might be surprising to some, but it is the reality. And a good number told us that it's combined with other roles. So very few dedicated chief digital officer roles. That's really the takeaway from our research. They're either combined or folded into the CIO role or are part of other roles. But we are seeing an emerging trend where some of the larger health systems are appointing full-time chief digital officers. And interestingly, in some cases, they're coming from outside of the healthcare industry. We asked them, where are they getting their budgets from? And the answer we got for the most part was that it's all part of the IT budget. And it's not surprising if the chief digital officer role is also part of the CIO role. Your budgets are going to come from IT budgets as well. About a third of them told us there is no specific budget for digital. And a good number also told us that the budgets are kind of scattered across multiple departments, and whenever the projects come up or whenever initiatives come up, they get funded based on whoever is interested in doing it. Digital platform strategy, we asked them, what is the strategy? And as you would have guessed by now, either EHR platform is a digital strategy for almost half the respondents that we talked to. And it's consistent with Model 1 in the earlier slide that I had presented. But then a good number also said that they're building or buying solutions based on immediate needs. Right. And here's the last slide on the research. Now, this was probably the most insightful piece of information that we got from the research study that we did. Nearly 2/3 of the CIOs that we talked to told us that what is impacting digital strategy execution the most is a lack of organizational readiness. And that could mean a lot of different things. It could mean that the leadership is not ready. It could mean the organization is not financially ready. It could mean that, in fact, one of our respondents told us, hey, we just implemented an EHR platform. We are reeling from that experience. We don't have the appetite for anything big right now. So it's everything in between. And this is an important factor because you might see this as a necessity in the market, but if you're not ready as an organization, then it's going to be very challenging for you to develop an enterprise digital roadmap and roll it out. With that as the background, I am going to turn this over now to Dr. Rasmussen. Peter? Watch for the slides.
Yeah, I saw that. Thanks. Good morning, everyone. So my role at the organization is medical director of digital health, and I've been functioning in this capacity for about the past 6 to 7 years, and perhaps even longer, depending upon how you want to mark the calendar. But the organization took a new direction about a year and a half ago, year and 2/3 ago, when we migrated from our former CEO, Toby Cosgrove, to a new CEO, Tom Mihalovic, and set a slightly different direction for us. Toby had always been very much patients first, and Tom wanted to add on several others, significant pillars for us. So in addition to being a patients first organization, we are very concerned about caring for the caregivers, caring for our community, and caring for our organization. So frequently, he will admonish us to treat every financial resource as if it's our own checkbook. So in each of those categories, then, we sought to find ways to use digital to improve our interaction with our community, to empower our caregivers. I see what you're saying here, Patty. A little disconcerting. Empower our caregivers. What I constantly tell my digital health team is our job is to make the lives of our patients and our caregivers better. And from a patient standpoint, we want to try to activate, empower, and engage our patients because a engaged patient is one who is a better partner in their overall health. And clearly, we need to work to steward the organization's resources to keep us viable into the future. And everything is grounded in our fundamental core values of quality, patient safety, and caregiver safety, and patient experience. So we've been doing telehealth or digital health at Cleveland Clinic for a long time. For those of you who are old enough to remember Skylab and the space stations that were circulating, the manned stations that were circulating the Earth. I think in the early 2000s, the Cleveland Clinic transmitted an EKG from the space station to the ground for interpretation. I think one of the astronauts was having some health issue, which is really one of the first digital interactions that we had. And then about 16 years ago, recognizing the market trends in stroke care, which is what I do in my clinical arm, was the advent and growth of telestroke. And that's really the time when we jumped into a lot of medicine as a distance, which is what Toby called it initially, was building out a telestroke program. And that started 16 years ago. That's now grown to about 17 different hubs and about 2,500 patient interactions each year. And out of that role, Dr. Cosgrove really wanted to move the organization more toward the future, recognizing that telemedicine was going to be a bigger role for healthcare overall in the future. He created the distance health team then about 6 years ago. When you're doing something like telestroke, which I'm sure many of you in this room are doing, either as a hub or a spoke, what you recognize is that the technology really isn't dependent just on that one particular use, that once you have that ability to do a rapid, high-quality, high-reliable, quick connect between a patient and a provider remotely, that you can use it for virtually anything. And what we recognized out of that is instead of trying to build out technology solutions for individual use cases or programs, that we were far better off economically to develop a platform of technologies that would allow us to innovate and deliver clinical care in multiple different ways. So as an easy extension out of the telestroke program grew things like telepsychiatry into the EDs and tele-neonatal critical care. So our pediatric ERs are actually separate from where our neonatal ICU is located. So when sick babies come in, the EDs, the neonatologists project themselves into those pediatric EDs. So these are very useful things that can be all done off the same common technology platform without adding an additional cost. Clearly, that's an inpatient or a provider-to-provider or provider-to-patient solution when they're in a healthcare setting. And what we didn't have at that time was the ability to offer ambulatory virtual visits for patients. So that was one of the first things that we did, was to build out a platform to allow us to do that. And like many organizations, we got our feet wet by starting off with on-demand virtual visits. And once we understood how to use the software and integrate it into our existing electronic health record and our billing systems, then we're able to carry that on to schedule virtual visits. And we now have about 70 different specialty departments delivering scheduled virtual visits with our patients around Ohio and the surrounding Midwest and even beyond. We're doing about 40% of the virtual visits are on demand, express care type visits, and the balance then 60% are scheduled virtual visits. And by far the biggest users of this is the neurological institutes, where it's really enjoyed a lot of success and adoption, where the providers have been visionary in terms of patient experience and how to extend their reach and brand. So in 2019, I think we're on track to do about 90,000 virtual visits across the organization, which may be pretty good amongst health systems. Maybe some of you from health systems are doing more than that, but really it's a puny number when you stack that up against Teladoc, which I think are going to do about 3 million virtual visits in 2019 or even more. So I think health systems, if you're thinking about getting into virtual visit game, I would strongly recommend that you ought to do it quickly, because Teladoc, American Well, MD Live, these organizations are coming up pretty quickly. So Toby drove virtual visits quite heavily. Our new CEO has picked this baton up as well and has set targets for us. To try to achieve these targets, we also include other types of telehealth interactions with this. So we have an online second opinion program, where if you're looking for a second opinion about an existing diagnosis or treatment plan that you may have, feel free to go online and submit into this program if you're looking for this. This is a direct-to-consumer model, as well as a direct-to-payer model as well. And we've implemented some other tools like wearables and ways for patients to share their imaging with us as well. So Dr. Mihailovic, our new CEO, has set a target for us by 2023, said he would like 50% of all ambulatory visits to be done virtually. If you can see the graph on the two graphs that are there, the orange or the bottom curve is what we would be doing if existing growth rates trended forward. And we need to really be tracking to the upper curve on the left. So we got a lot of work to do to move the needle, if I dare use those words. And that is really what our main challenge in the organization is right now, is managing that change and delivering care from our standard operating model to one that includes more virtual visits. So we do value the patient experience. I have to live, eat, sleep, and breathe this, and literally I do, because my wife is the Chief Experience Officer at the Cleveland Clinic. I do believe in it, though, to be honest with you, and I do have very high patient satisfaction scores, if I do say so myself. But there's a lot of, and I really get some fascinating insights from her, because when patients fill out their surveys and they come back with their verbatims, she frequently reads several of them to me every week, and it's really pretty fascinating to hear what patients have to say. And one of the things that she did is, when she first became the Chief Experience Officer, she did a survey of our patients and how far they travel and how much time they spend in our waiting rooms and how much time they spend with our providers. And would it surprise any of you that the average Cleveland Clinic patient spends 2.5 hours traveling to and from our organization? Would it surprise any of you that our average Cleveland Clinic patient spends 25 minutes sitting in a waiting room? And the average Cleveland Clinic patient spends about 12 minutes with a physician. I don't know how anyone considers that a proper patient experience, and that is what most clinical leaders and physicians and providers in your organization consider to be the gold standard. I personally find that to be abysmal. I don't know what about an in-person visit actually is the best, That to me is the worst care delivery. In my own practice in cerebrovascular neurosurgery, unless you've actually had a stroke, you don't actually need to come in and see me. There's no reason in the world for you to be in my office. We can do everything we need to do by electronic review of imaging and a virtual visit. And it's amazing that more physicians haven't really adopted this. So when we took a look at the patient experience after we initiated virtual visits, we found that the vast majority of patients were seen within less than 5 minutes. 72% were seen within 5 minutes. And remember, those patients who are waiting in their home, or maybe they're waiting in their office at work, or maybe they stepped out and went into their automobile in the parking lot from their office to have a modicum of privacy. So it's not the same as waiting in that Cleveland Clinic waiting room with CNN droning around in the background and a 5-year-old U.S. News sitting on the table. So it's a much nicer wait when patients are doing that. And I find frequently when I'm doing virtual visits, patients are snacking with their family, or they collected their family around them, or perhaps some of them are cleaning up the kitchen before they actually get on the virtual visit with me. So this is not wasted time for those patients, and they're certainly not doing that travel. When we looked at the on-demand experience that patients were having, about 40% of the patients said that virtual visit was going to replace an in-person urgent care visit. 25% said it was going to replace a walk-in express care clinic, and 12% said it was going to replace an ER visit. And obviously in the value-based world, that's an incredible cost savings for us. And perhaps most disheartening about all of this here is that 10% of patients said they would do nothing, which means that they're just going to hope that they're going to get better over time and not seek care at all. So this is clearly a good access solution for many patients. From a physician standpoint, I frequently hear from my colleagues that, boy, I'd get going on virtual visits, but it's just going to slow me down, and I'm much faster if I'm in the office. Well, it's a very rare physician's practice where you're actually better off seeing patients in person than online. So I can tell you from personal experience that I spend less time with patients in a virtual encounter than I do in an in-person encounter. And that slight distance that virtual visit puts up between myself and that patient, you eliminate some of the usual social niceties. It's just not quite appropriate in that environment, and patients frequently want to get down to business much faster. And about two-thirds of the time is spent on a virtual visit you would in an office visit. And that's just not my practice. I repeatedly hear this from the physicians who have embraced virtual visits wholeheartedly. So a much better patient experience standpoint in the amount of time that they're spending with everyone and where they're waiting. And then if you look at things like, is it easier for me to get care when I want it? Did I have enough time with the doctor? Am I confident about privacy, et cetera, et cetera? Very, very high marks, 90%, very good satisfaction ratings for this. So when we did a matched study on this between on-demand urgent care type visits with our walk-in express care and urgent care clinics, we found that we had about a 85 to 90% high-level satisfaction with our patients on those virtual visits. And when I remember making this presentation to Dr. Cosgrove after we started this, the head of the Emergency Service Institute jumped up and said, "Aha, you only have 85% satisfaction." And I said, "Well, I'm sorry, Brad, but here's the next slide. You only have 75% in your walk-in clinic." So again, it goes back to that in-person visit is really the gold standard, best way to deliver care, when the reality is if you look at any patient experience metric that you're going to be measuring in your organization, virtual visits will beat in-person visits on every measure that you're looking at. Hey, did you want to talk about this, or do you want me to continue with this?
Go ahead. Yeah.
So the organization took a dive into developing a formalized digital strategy about 1.5 to 2 years ago. And the first stage in all of this, which Patty and his team were helpful, our organization moving through this, was to sit down and talk to all the various stakeholders around the organization, the clinicians, the patients, the billing people, the legal teams, et cetera, everyone that really would have a stake in expanding the role of digital health and understand what we needed to do as an organization and where we were going to go. And then a fair amount of time was spent documenting what the particular concerns were amongst all of the different stakeholders. And then, of course, we came up with about 150 to 200 different items that we thought we could move in different directions and transform the care for our patients, our caregivers, and other aspects of the organization. And obviously, you can't do all of those things. So then we engaged in a lengthy prioritization project. And then there were obviously things that we wanted to do as an organization that we couldn't, that we didn't have the technology for. So then we initiated RFP processes, obviously, to solicit vendors that would work to help solve some of these unsolved use cases that we had. And that's really that stage 4 of the roadmap that Patty showed earlier, where we are actively working with now 2 potential strategic partners to develop out the solutions for the unsolved use cases that we have at this point in time. So as part of this process of working with the stakeholders around the organization, as we engaged on journey mapping, here is an example of some of the journeys that we mapped out from the patient domain. And an example of one of these that I'm going to talk about here amongst all of these is that we're an Epic shop, and really we really didn't have a good mobile experience for our patients. Like many of you who use Epic, we're basically using MyChart, if you're familiar with this. This is not a good solution, at least in our opinion. It does a lot that you want it to do. But from an organization that views itself as a global healthcare brand with operations internationally, and in 2021 we'll be in London, in case you didn't know that, we needed to develop a branded Cleveland Clinic-specific app for this, and that was one of the things that came out of this journey mapping. So going live in November of this year, we will be switching off of MyChart to a in-house developed and built app that will incorporate MyChart functionality, also with virtual visit functionality. Right now we got patients downloading 2 different apps to do these things. And then as we have more and more patients move on to wearables and remote patient monitoring at home, we'll be incorporating in there a middleware software solutions. So again, patients don't need to download any additional apps. So once they download our app, it will be a one-stop shop for them in all of the different ways that they'll digitally interact with us moving forward in the future. And then we also took a look at the caregiver domain and wanted to understand ways that we could digitally enhance their day-to-day lives. How do we make their lives better? One of the things that came out of this is that we didn't have a good solution for provider-to-provider texting. And it was quite a simple fix for us, because many of you know who are using Epic, that's a functionality that exists within Haiku, Canto, and now Hyperspace, and that was just a matter of us to move those gears internally to bring that forward. But this is met with a lot of caregiver satisfaction and success by just simply adding on that extra digital tool that we didn't have. So with Patty and his team's assistance, then we moved into a matrix of prioritization initiatives. We divide them up into. I'm sorry, Patty, do you want to speak to this, or?
Sure.
I can keep rolling if you want.
Yeah, that's fine.
All right, I'm sorry.
Or I can just speak on the mic. Stay there. It's all right. So this, can you hear me? Can you hear me? Okay. So this prioritization matrix is it's a very useful tool, and I would urge you all to take a look at this and see, if you can apply it in your own organizations. Essentially, we've kind of mapped out all the use cases along 2 dimensions: level of effort and the level of impact, right? And so anything that has a low level of or a moderate level of effort and has a high impact is obviously a near-term win that you can implement. But it doesn't mean that you ignore the long-term strategic bets as well. So if, for instance, you want to really, really transform your patient experience, you may have to implement a CRM system and then build solutions on top of that to improve the experience. Now, the CRM implementation itself is maybe an 18 to 24-month project. But in the meantime, you have to keep doing other things, knock out the quick wins, but then lay the foundation for the strategic long-term plays as well. So these are not the actual use cases that were eventually put into the final roadmap, and as Peter mentioned, it's still evolving. But this is a very useful tool, and the color codes there also help you to identify which journey map they belong to. And you can identify whether they are a part of the patient journey, whether they're part of the caregiver journey, and so on and so forth. And it helps because you can then align all of these to enterprise priorities. So, and in the following slides, you're going to see what the Cleveland Clinic enterprise-level strategic priorities are when it comes to digital transformation, and you'll be able to appreciate that as well. Go ahead. You want to talk about this one too?
Sure.
Oh yeah, this is actually the big takeaway from this slide, and there's a lot of small print there. I'm not going to walk through any of that. The big takeaway from this slide is that there is no such thing as a single digital platform out there. So if you're looking for one, stop looking. There isn't one. You're going to have to develop your own digital platform architecture and implement it using either platforms that you've already invested in or you plan to acquire based on your needs. And so what this means is you're going to have to look first at enterprise priorities. You're going to have to look at your existing technology footprint within your organization, look at the dependencies involved, and finally, choose your trade-offs. Peter just talked about swapping out MyChart with a brand new patient app. Obviously, big trade-offs involved because there's MyChart, it's already invested, it's available, it's out of the box. But you want something better. You want to significantly move the needle on the patient experience. Well, you're going to have to spend on it, and you're going to have to put in a lot of effort to develop it and roll it out and so on. But you're making some trade-offs. Right? And these kinds of trade-offs are going to be a big part of any digital roadmap that you implement. And there'll be big decisions to make. You may have to rip out some existing platforms that you've already invested in or consolidate them into one or find something new out there that serves your needs much better than what you already have. So all of these go into your digital platform strategy, and that's really the big message here. There is no single platform out there, and I know there's big tech firms who will want to convince you otherwise, but we have done our research, and we've gone deep into what's really available out there in the market. I won't spend any time on this. This is just a framework that we use for evaluating different kinds of technology partners, and we can jump through this, Peter. The handout is available for those who want to look at it. RFP, you want to talk about that?
Yeah. So after we developed the list of use cases that we were interested in moving forward with and did the prioritization, then we issued an RFP process and had several or many of the very large tech companies around the U.S. engaged with us, and sat down with them and talked with them in depth about things that we wanted to do and where we're at and what they could possibly do, and eventually narrowed that down to 2, and we're very close now to making a final selection of that. So as I mentioned, the organization moving forward has set a goal for us by 2023 to have 50% of the virtual visits, outpatient visits transferred to virtual or digital. The slide's slightly old from when it was submitted. We've no longer said 25% of our inpatient days at home, but we have changed that target now to 25% of inpatient encounters are done digitally. So in our healthcare system, what does that mean? In our health system, we have, as an example, 15 hospitals in Northeast Ohio. Not every hospital has all of the specialty services that are needed in each of those locations. So if we need to do remote cardiology consultation, neurosurgery, hepatology, et cetera, we are and will be expanding the delivery of specialty care digitally in those venues. As Patty's alluding to, the technology platform strategy that we've adopted is that when Epic has a functionality available that we want it to do, it meets our organizational strategic priorities. We use Epic tools whenever possible. When Epic then fails us and doesn't offer the solutions that we look for, we then look for outside partners who can do the work that we need done. Example, higher analytics or CRM solutions as examples of this. And then if we can't find an appropriate industry partner to do what we want to do, then we'll do the work internally. And that's the conclusion we came to with developing of the unified global patient app that I was talking about. We have had some challenges and barriers to adoption. Obviously, one of the biggest concerns that every organization is going to have is the data interoperability between the disparate digital systems. To help overcome that challenge and barrier within our organization, Like most of you, we maintain our own team of Epic programmers and API specialists. So we've built out a full API layer that sits on top of most of our digital systems that allow for data transmission and interchange between these systems, as well as HL7 and fire programs as well. We're still working on developing that last bit of the digital strategy and strategic relationships. But as I mentioned, those will probably be closing before the end of this calendar year. One of the biggest challenges we've had as an organization is at the clinician end is the adoption of more digital technology in their practices. As an example of this, we have 3,500 physicians in our organization, and only 1,000 of them are active users of Dragon voice recognition. I don't really quite understand what the barriers to this, because this is nothing but a speed enhancement in your practice, but I think it's just an illustrative example of the unwillingness of many physicians and clinicians to change how they practice to adopt technology into that. These are things that can be overcome, in my opinion, at the executive physician leadership level. And we had our most gains as an organization when the CEO was personally involved with driving digital adoption and digital transformation of care delivery. So I can't stress that as enough as a major solution to this. Clearly, as Patty mentioned, many of these solutions are going to require funding to implement these things. Most of the stuff you can't do internally, and you do need to get partners for this. And of course, every one of you is working in an organization probably where you're told to reduce your budget by X% next year. So coming up with those funds for these things is not always easy to do, and there's going to be haircuts and pain in someone's budget. And then, of course, as an organization, you're always going to have to wrestle with the question of, well, there is some existing functionality in our EHR. We're paying big money for that. Why don't we just use that functionality? Is it really just good enough or not? And then you need to bring to bear, obviously, the key stakeholders on this and your governance functions, et cetera, to help wrangle with those decisions that need to be done and understanding whether you need to move on to a separate vendor. So, from my standpoint, the major learnings I've had over the past 6 years is how important it is to have the CEO level buy-in on this and the highest level of physician leadership buy-in and adoption. Particularly in an organization like ours where we're employed, there are very few carrots to use to help engage this type of transformation. We as an organization really moved to a soft stick approach, which is frequently reviewed dashboards of behavior. And that seems to have been a way to move a lot of this work. Currently, a lot of the digital work sits inside IT. As Patty was mentioning, some of it does sit in IT. Much of it sits outside in other areas. As an example, Office of Patient Experience, Chief of Staff Office, specialty institutes, et cetera. A lot of finance. All of this stuff needs to be brought together, and people need to recognize that it's not just an IT initiative, but it's an organizational initiative. It has been worthwhile for our patients and our caregivers to work heavily in this area. Because there's examples every day of how we've made patient and our caregivers' lives better and more efficient. And the last thing that I just want to reemphasize is what Patty already mentioned, is that if you think you can go to giant tech company X and pay them a wad of cash that they're going to solve your digital problems, that's just simply not the case. It does require evaluating multiple technology vendors as you move into each of these different domains of where you want to operate, understand who is going to be the best partner for you and what's going to meet your needs, and understand what that is, because none of those giant tech companies can fill the bill, and even the mid-sized companies are really only going to address a portion of what your digital transformation should be. So I'll let Patty wrap it up here.
So just to bring this all to a summary here, I think the three key takeaways are, number one, secure leadership support for your digital transformation program. And that means at the highest levels of the organization, and possibly at the board level, because these are decisions that are kind of bet the farm kind of initiatives in many ways. These are multi-year programs where you make commitments today that have very long-term implications. So, and if you saw in the research that I shared with you, I mentioned that organizational readiness is one of the biggest challenges. So make sure your organization is ready. And so the second takeaway from that is develop an enterprise roadmap where you're involving everyone. So it's, make sure it's not seen as an IT initiative or a marketing initiative or some, individual function. Even though the leader for the transformation initiative could be the leader for a function, the initiative itself needs to be seen as a cross-functional initiative where all stakeholders get an opportunity to have their say. And I can't emphasize enough how much the Cleveland Clinic, took that to heart when actually going through the whole roadmap process. We had a team, I think, of extended stakeholders, which is about 50 or 60 people, if I'm not mistaken. And it's going to slow you down a little bit, but the outcomes are going to be good at the end of it, because there's no one, who can come back to you later and say, hey, you never involved me, you never told me, I didn't know this was happening, I'm not on board. You just don't want that. Plus, it's the right thing to do, because enterprise digital transformation is really what that means. It is enterprise-wide. And there are opportunities everywhere. You just have to look, and then, the stakeholders will tell you where the opportunities are. So, make them part of the process. And then the last part is identify key technology partnerships. I can't tell you how many technology partners talk to us, how many we talked to, reached out to. We talked to peer group health systems to find out what they were doing. And they were all very generous with their time. Ed Marks, the CIO of Cleveland Clinic, he reached out to his peers across the country. And they were all very generous with their time. We talked to them and we asked them what they were doing, what they were focusing on, what were the challenges they were seeing, what kind of technology partnership strategies they had. So we took all of that. We talked to the technology partners as well, both existing partners as well as those that we were considering seriously. We went out to Silicon Valley and talked to a bunch of startups, and we asked them, hey, what do you have going on, right? Because we knew that they had, some of them had interesting solutions. But we also came away with a feeling that, while some of these solutions are very innovative and we'd like to implement them, there's a lot of risks involved. There's financial risk, there's technology risk. They may not survive another 2 years. They're running on VC money. There's a whole bunch of other issues to take care of. And so how you integrate innovation into your roadmap is also an important factor. So that's kind of it from my end. And Peter, unless you have other closing comments, we can open it up for questions. Yes, sir.
Very short question. Doctor, you said that you have about 3,500 providers and only 1,000 are using, and I didn't get what you said, my chart or part of the digital platform. Yeah, sorry.
Only 1,000 are using Dragon voice recognition to help them with notes. I guess it depends on how you want to measure it. So there's, we use the dyad model paired up with an executive director, and then there's probably about 6 or 7 people who are direct reports there, who are we term digital adoption specialists. So these are sort of at the elbow support, if you will, for our clinicians to help them envision and change how they can use our digital tools to transform their care. And then there's a good portion of individuals in IT proper, if you will, like the Health Information Exchange team, the API team, the mobile and web app developers who all chip in on these projects as well. So kind of it's hard to measure, but I don't know, somewhere between maybe 10 and 90 people, depending on how you want to count them.
Please.
From a patient education standpoint, what, if any, education or communication can we do to encourage patients to adopt this virtual model, and feedback that you may have received about anything they've received they were losing or that they wouldn't get by the
Yeah, so about 4 or 5 years ago, when Dr. Cosgrove really wanted to put a lot of energy behind this, he devoted 80% of our enterprise marketing budget directly to patient education about virtual visits. And that continued for 2 years. And then there's still I'm going to guess probably 50% of the advertising budget is directly related to patient awareness around digital activity. And obviously some of that was also directed toward the caregivers as well. It's a rare patient who doesn't want to have a virtual visit. In my mind, most of the patients who don't want to have a virtual visit with me, as an example, just really are in it for the social interaction. You know, they want to make the trip into Cleveland and get lunch afterward or something like this, and it's an excuse for them to get out of the house. But otherwise, most patients are very, very favorable to it. You know, there are entire patient groups who want virtual visits, right? As an example, cystic fibrosis patients generally don't want to come into the dirty office and pick up some bacteria that they're never going to get rid of. Patients with movement disorders, we've had incredible buy-in. You know, having a bad Parkinson's patient travel 150 miles across Ohio in the middle of winter to walk 200 yards across an icy sidewalk and then through our lobby is not a good use of that person's time and safety. And it's even better for our caregivers when we speak to our movement disorder specialists. It's better for them to see the patients and how they move in their home than in their office. It gives them better insight on how to manage them. So when I talk to my colleagues, physician colleagues, and they don't want to engage in virtual visits, I'm actually just amazed about it because it is the worst care delivery model in my opinion. You can only go so far with a virtual visit, right? There's certain aspects of the exam you can't do, but there are technologies available now where you can do a general medical exam remotely. That's been solved. If patients need laboratory, in October 15th, we'll be turning on a bidirectional interface in our EHR that will, where our clinicians can send an order to Quest or LabCorp nationally, so the patient can just go to their local lab and get that done, and that will result back in our in-basket like it was generated within our organization. And then we have a network of imaging centers scattered around Ohio, so if I see a patient in Dayton who needs an MRI scan, go to our local imaging center and get it done. I'll write the order in here, and it's picked up, and I view the MRI, 2 days later after it's done. So there's a lot of ways that, or if they don't have one of our imaging centers, I can easily send out that order, and then we've got an image upload strategy where patient can just electronically transfer in the images off of a disk. So there's a lot of solutions that can be put in place that can extend your health system's reach digitally to avoid these in-person interactions. I know there's some people, I think you had your hand up a while ago.
So, first of all, thank you. On this patient experience, and I love how you intertwine the
So I just got to ask, do you know my wife? It's Adrian Boise.
Your wife is my hero.
She is by far the better half, yes.
She's amazing. So, you mentioned in the challenges the financial piece. Can you build on that a little? How is the yes, it's easy for us to say, well, there's so much money, but we still need money to operate. So how, as far as I know, you don't get reimbursed for digital yet as much. So when we move towards e-visits, how does that work financially? What's the ROI? How do you present the organization?
Yeah, so first of all, I would start with the CEO support's very, very important. And what Dr. Cosgrove said, well, let me take a step back. So the reimbursement for virtual visits and digital health is going to be done on a state-by-state basis. Ohio is very bad in this regard, and only recently have they passed legislation for virtual visit coverage. That doesn't mean payment, and that doesn't get implemented for quite some time. So we really leave it up to a provider and department level decision about charging for a virtual visit. So at the highest level, Dr. Cosgrove's mandate was, you will do virtual visits. It wasn't, you will do virtual visits and get paid. It was, all I want you to do is do virtual visits. I don't care if you get paid or not. He just wanted us to get going on this, get the patients bought in, get the providers bought in into doing virtual visits. Second of all, cash is a very real option, okay? And I have this conversation all the time with physicians that somehow physicians are have this fantasy that their patients are there for free and that they're not paying anything, right? And it's very, very much on patients' mind that they're paying something, and physicians are generally loath to have a conversation with patients about paying cash. And I don't really quite understand this because, you're a patient, you're going to pay for this visit, and you're going to have a copay, and you're going to have parking fees, and you have to pay gas, and a friend or a spouse is going to have to take time off from work, and all these things cost you things. And frequently, the cost of a virtual visit, even if it's cash, is going to be less than what their copay is, to be honest with you. So this is not really a barrier in my mind. And then it may be in the patient's financial best interest to pay cash for this. So I get a lot of second opinions coming out of New York. The neurosurgeons tend to be quite pushy there. I'm sorry if anybody's here from New York is a neurosurgeon. They tend to be quite pushy. Frequently patients take a step back and say, no, maybe it's really not as much of an emergency. Let me get another opinion. Boy, this Cleveland clinic might be a way to go. Not a big deal for me to fly to Cleveland. My nurse will just transition that to a virtual visit, and she'll know these patients are coming from Manhattan, and this is $300, $500 cash is going to be nothing for them. And then the other way to think about it is this is a practice building tool. So if I do some type of unusual type surgery, maybe I do robotic mitral valve replacement or something like this, patients around the country might want to come to Cleveland for that type of surgery if they're a candidate. It behooves the surgeon to do that initial virtual visit for free in the hopes that they're going to capture that patient to travel to Cleveland for a very expensive surgery. So I don't even think about the finances when you think about it, when you put it in those terms and think about it. It's just a much, much better way to do the business. And then think about when you have a patient pay cash, your back office expenses drop dramatically because you're not chasing down all these bills and sending out bills and all these kinds of things like this. So there's a lot of upsides to all of this.
Any other questions? Oh, sure. Go
You
ahead.
mentioned that you suggested that we begin telemedicine due to the teledoc services. Is that due to a threat to market share or to physician recruitment retention? Both?
Well, there's a lot of different aspects to this. There are clinicians who are sitting on the sidelines who are not doing patient care because the current delivery models don't meet their lifestyle. So this was very eloquently illustrated to us when we were trying to meet our headache access targets. So we try to see every patient in a specialty clinic within 7 days. That was never happening in a headache clinic, as you can imagine, because everyone's got a headache. So we decided we were going to recruit more nurse practitioners to do this, and effectively we couldn't find any nurse practitioners in the Cleveland area, but we found some that lived in Akron. And when we broached to them and said, do you want to do a headache access clinic virtually, they jumped at it because they never had to leave their home. And now they each do 14 appointments a day virtually, Monday through Friday. And we're able to improve our access overnight dramatically. And the patients love it, and we're able to bring in these providers that were sitting on the sidelines otherwise. And there are other people who want to transition a portion of their bricks and mortar practice to virtual. They just view it as a better way for their lifestyle. Or perhaps we have a lot of females who in primary care who go out to have a baby, and then on their way getting back into their routine, it's easier for them to do virtual visits for a few months before they transition back into the office full time. So there's a lot of ways to do this and keep people engaged. My comment specifically about Teladoc is that Teladoc started as an on-demand urgent care type care delivery solution. And they subsequently expanded into delivering second opinions. They bought Doctor on Demand. Best Doctors. They bought Best Doctors. So now they deliver second opinions. And now they're moving into the primary care space. And they've bought several telemedicine companies in Europe and Mexico. So over time, Teladoc is going to become a trusted brand in medicine. It'll just take a matter of time. And they're already doing 2.5 million virtual visits a year. And that number is growing by, I think it went up 1 million from the year before that. So they are an international healthcare delivery company that's fully virtual. And that scares me, right? Because I don't say anything bad about their health care. I'm sure it's very, very good. But it's a non-traditional healthcare provider. Is this who should be doing this, or should you as a healthcare system do it, or Cleveland Clinic or, whoever, and not Teladoc. Yes, sir.
To that end, what are your thoughts on organizations that don't have the ability to stand up their own online visits capabilities, partnering with Teladoc when getting in the game?
Well, I mean, so Teladoc is going to do the technology piece, right? And then if you as a health system need providers, that is a solution. We do that to some extent. We have a portion of our on-demand visits done through outsourced labor pool, yeah. I don't see a problem with it if it's going to get you going and get your health system in it. Look at them as a technology vendor, and then if you need some wraparound or backup labor, that's what you got to do. That's what you got to do. Yes, ma'am.
This is a massive effort. Can you share the marketing of front to acquire new patients? And I can see where once they're in the program, you're looking at their labs, and you're looking at their physicians and some of the things. But what about the acquisition of patients that may not be familiar with these services?
Well, we've had a lot. So we did I mentioned a lot of marketing in the Northeast Ohio area market. So patients would find us for on-demand that way. And we did all the traditional stuff too, email campaigns and on-hold messages and all of this kind of stuff like that. And now patients are organically finding us. So through Google search and things like that, they're just landing on our webpage or download our app, and they're organically finding us now as we sort of get to a critical mass on this. And of course, the brand helps to some extent as well in terms of acquiring that. Our CFO constantly calls myself and Matt Stanton, my executive director, on those calls up and say how much of a massive money loser we are. And I'm like, you got to run these numbers through for me because we're paying almost nothing for our technology platform, and he will factor in all of the expense of the marketing dollars onto our virtual visits. And I'm like, that's just completely wrong, Steve. You can't do that, right? This is patient education for the future. It builds the brand, everything that goes along with that. You can't lump that marketing expense onto this digital, the virtual visit program. That doesn't make any sense. You got to. It's like everything else. It's got to be spread around, right?
One more question.